With that, ladies and gentlemen, we'll now proceed to Symposium 22 in Hall B, which is dedicated to cardiology, with updates on acute coronary syndromes, management of heart failure, and long-term management of strategies for chronic coronary syndromes. It is my pleasure to invite our chairpersons, Dr. Gotabhaya Ranasinghe and Dr. Naomali Amarasena. Now I warmly invite our chairpersons to introduce the speakers and panelists for this session.
Good afternoon. I'm happy to see such a nice, well-represented group here, and even at the tail end of the very successful academic sessions we've had. So what we are going to have now is the Symposium in Cardiology, and that will consist of basically 3 topics, that is acute coronary syndrome, heart failure management, and chronic coronary syndrome. I'd like to invite all our panelists also to come and join us, and that is Dr. Bhathiya Ranasinghe, Dr. Tanya Pereira, Dr. Disna Amaratunga, and Dr. Mubarak. Without delaying anymore, I'd like to introduce our first speaker, Professor Rohan Jayasinghe. He will speak to us on integrating new guidelines into practice in acute coronary syndrome. Professor Jayasinghe graduated from the University of Sydney with first-class honours, training in cardiology at Westmead Hospital, Sydney, and completing an interventional cardiology fellowship at Mount Sinai, New York. He's a fellow of the Royal Australasian College of Physicians in both cardiology and internal medicine. He holds a PhD in cardiovascular research and master's in sports medicine and business administration from Newcastle. He's the head of cardiology at Gold Coast University Hospital, Foundation Professor of Cardiology at Griffith University, Professor of Clinical Medicine at Macquarie University, and Adjunct Professor at Bond University. Professor Jayasinghe has been the principal investigator in over 100 clinical trials and authored more than 100 peer-reviewed publications. His expertise spans coronary and structural interventions, acute coronary syndrome, heart failure, sports cardiology, and cardiac prevention. A global speaker, inventor with multiple patents, and past editor-in-chief of the Australasian Journal of Cardiology, he has also contributed to national policy and guideline development in Australia. So Professor Jayasinghe will speak to us on acute coronary syndrome, integrating new guidelines into clinical practice.
Thank you very much, Dr. Ranasinghe, for that very kind introduction. And I'm both honored and privileged to be giving this talk. And I thank the organizing committee, Professor Katlande and Dr. Ranasinghe, for giving me this opportunity to give this talk today. So my talk is going to be on acute coronary syndrome, integrating new guidelines into clinical practice. And I'll be focusing on recent updates to the guidelines that have been published this year. So this is a snapshot of our hospital on the Gold Coast in Australia. So it is very important when you look at guidelines to recognize that they are not there to replace good clinical judgment. They are to complement good clinical judgment. And it's important to maintain an open and clear discussion and a dialogue between the clinician, the patient, as well as the patient's relatives who be involved in their care, to make sure that the treatment plan is individualized based on the patient's values, preferences, as well as the clinical context. If you look at guidelines, particularly the American guidelines, there are 2 elements to it. The class that defines the strength of a guideline. Class 1 is a strong recommendation, whereas when it comes to class 3, it is considered the intervention is either useless or potentially harmful. And all recommendations are based on evidence that is defined as a level. And the level of evidence is best when it is based on a meta-analysis or multiple well-controlled randomized controlled trials. Let's look at a case, a 7-year-old man who presents with chest pain of 8 hours duration. He has the risk factors of diabetes and hypertension. The ambulance gets to him within 15 minutes upon being called, and the patient arrives in emergency department. So this is a quintessential patient that we all encounter in our day-to-day clinical practice. This is the first ECG that was obtained of this patient. You can see that there's ST elevation in the inferior leads and some element of marginal ST elevation in the septal leads as well as the lateral leads. How would you approach this patient based on the current guidelines? So briefly, I'm going to give you an overview of what acute coronary syndrome is. It's essentially reduction in blood flow due to an element of occlusion in the coronary artery, leading to either threatened or real myocardial damage. And it is important to categorize the type of acute coronary syndrome based on biomarker positivity as well as ECG findings to unstable angina, non-ST elevation myocardial infarction, or ST elevation myocardial infarction, or STEMI, because that defines the treatment strategy to be adopted. Most guidelines published primarily address acute coronary syndrome due to atherosclerotic plaque rupture. However, there is some mention of acute coronary syndrome due to oxygen demand mismatch, i.e. type 2 MI, and also some mention on unusual causes of acute coronary syndrome, such as spontaneous coronary artery dissection. So this is a snapshot of various pathophysiological mechanisms whereby acute coronary syndrome takes place. Plaque rupture and thrombus formation, dissection and hematoma formation, and leading to stenosis of coronary artery, thromboembolism, or coronary artery spasm. And type 2 MIs can be caused in the context of a normal coronary artery or a diseased coronary artery. Recent updates of guidelines were published by a panel of experts put together by American College of Cardiology, American Heart Association early this year, and subsequently this year itself, Heart Foundation of Australia as well as Cardiac Society of Australia and New Zealand also published their updates. So my talk today is basically focused on the Australian guidelines, but I have endeavored to incorporate some elements from the American guidelines as well. So ECG should be obtained within first 10 minutes of medical contact. So our patient had that. And if the ECG, index ECG, does not provide the diagnosis, and if the patient's clinical circumstances change, then subsequent ECG is indicated. Australian guidelines recommend continuous monitoring only if the patient has ischemic symptoms that are ongoing or if there's hemodynamic compromise with the availability of a defibrillator, whereas the American guidelines recommend continuous monitoring for all patients diagnosed with acute coronary syndrome. If the standard 12-lead ECG does not provide you with the required information, it is reasonable to obtain specialized ECG tracings, either posterior ECG or a right-sided ECG. High sensitivity troponin is the bedrock of diagnosis of acute coronary syndrome. Elevated high sensitivity troponin, sex-specific above the 99th percentile, is diagnostic of myocardial damage. And when you use serial measurements, it's important to make sure that you utilize the same assay because different assays have different parameters. Risk assessment in the setting of acute coronary syndrome. All these recommendations that I discuss are class 1 or class 2 recommendations that have been published. In the setting of an ST elevation myocardial infarction, STEMI, you do not have to adopt a clinical decision pathway. The patient should be provided with immediate reperfusion in the way of thrombolysis or primary PCI. Those who do not have acute coronary occlusion myocardial infarction should be risk stratified based on a accepted risk score, which I'll come to later on. And that risk score would help put the patient through a clinical decision pathway. Gray's risk score is the most recommended risk algorithm, both in the Australian guidelines as well as US guidelines. It gives you the 6-month mortality risk of the patient. All three risk scores utilize high-sensitivity troponin or biomarker as an element of risk stratification. Heart score is mostly used in the setting of emergency department. Even in our hospital, heart score is used by the emergency physicians for risk categorization. TIMI risk score has two elements to it, one for ST elevation myocardial infarction and another one for non-STEMIs. And the US guidelines have some mention of the utilization of TIMI score in the intermediate risk population. A Gray score of more than 140 is considered high risk. A score between 109 and 140 is intermediate risk. A score below 109 is considered low risk. So let's come to the therapeutic applications. All patients should be given 300 milligrams of loading aspirin orally unless contraindicated. Oxygen supplementation is recommended only if the patient is desaturating below 90% on room air. However, the Australian guidelines make a cautionary note about putting this saturation above 96% because that can cause potential harm due to free radicals. If the chest pain is persistent, treat the patient with GTN and also IV administered opioids such as fentanyl or morphine. In people who are categorized as intermediate risk, defined by a clinical decision pathway with elevated troponins, inpatient investigation or routine catheterization is recommended. And in patients with intermediate risk without troponin elevation, Australian guidelines recommend discharging for non-invasive management to decide on the need for coronary catheterization. So that's called selective invasive strategy. And the very low risk patient population, Australian guidelines do not recommend further investigation at all. So let's now focus on STEMI management. Any patient who presents within 12 hours of onset of chest pain should be given immediate reperfusion therapy. And guidelines recommend primary PCI as a preferred option above thrombolysis. And if the patient presents beyond 12 hours and remains stable clinically and asymptomatic, there's no indication for emergency reperfusion with primary PCI. Once again, if the patient presents within 120 minutes, primary PCI is the preferred therapeutic option. But if primary PCI could not be administered within 120 minutes, the patient should be provided with thrombolysis unless contraindicated. If you go down the pathway of fibrinolysis, it should be given within 30 minutes of first medical contact. And the Australian guidelines recommend and promote pre-hospital thrombolysis in the setting of patient where the patient is encountered or in the ambulance. Those who are over the age of 70 can be treated with half-dose tenecteplase. Now, this is a pivotal study that I want to focus on briefly, the CAPTAIN study that was published around 2006 that showed if provided within the first hour or stretching on to the second hour, non-diabetics do better with thrombolysis compared to primary PCI. That is the second graph on this slide. The first graph is the diabetic patient population. They did well with primary PCI. So therefore, thrombolysis is not dead yet. If you can provide it within the first hour, the golden hour, they will do better than being treated with primary PCI, potentially if they are non-diabetic. So those who are going to be treated with primary PCI, it should be provided within 60 minutes of presentation to the hospital. And if they've been transferred from a peripheral hospital to a PCI center, primary PCI should be provided within 90 minutes according to the guidelines. Radial access is preferred over femoral access, and guidelines specifically mention that thrombus aspiration of the index artery is no longer recommended routinely. And if the patient has been stable for more than 48 hours and asymptomatic currently after a STEMI, there's no room for routine intervention. Moving on, let's look at non-atrial myocardial infarctions. So all patients with non-STX should be risk stratified based on a risk score. Both guidelines recommend utilizing the GRACE risk score. If the patients to undergo invasive therapy, bleeding risk score could be utilized to assess the utilization of anticoagulant therapy. Very high risk patients should be taken to cath lab as soon as possible and revascularization be provided by way of intervention or coronary artery bypass surgery. Very, very high risk patients who aren't stable, ongoing symptoms or dynamic ECG changes should be taken to the cath lab within the first 2 hours upon diagnosis. Those who are high risk based on a GRACE score, as I said, more than 140, should be catheterized within 24 hours. So that is called routine invasive strategy for non-STX. In the setting of invasive treatment, radial artery access is preferred over femoral access according to the guidelines, and guidelines recommend utilization of intravascular imaging in this setting. Last year, Greg Stone and colleagues published a meta-analysis of more than 15,000 patients that showed superiority of patients' outcomes upon being utilized intravascular ultrasound, optical coherence tomography, OCT, in the setting of intervention versus not using these modalities. And there was no difference between the groups that had IVUS versus OCT. What about antiplatelet therapy? Those who have had fibrinolytic therapy should be provided with aspirin as well as Plavix. But for those who have had primary PCI or invasive management of non-STX, the preference is for a more potent P2Y12 inhibitor such as ticagrelor or prasugrel. Prasugrel is not available in Australia because of the high bleeding risk, but ticagrelor is. For those who cannot tolerate ticagrelor or prasugrel, they should be given clopidogrel. It's a very special mention of genotyping or platelet function study to decide on P2Y12 inhibitor choice is mentioned in the Australian guidelines. That is because 30% of Asian and Caucasian populations are resistant to Plavix. What about anticoagulation therapy? People treated with fibrinolytic therapy should be provided with ongoing heparin or enoxaparin therapy at least for 12 hours. For people who have had primary PCI, heparin is recommended as much as bivalirudin. So I'll come to why that is so, exploring the evidence base. Those who have had a diagnosis of non-STX should be treated with heparin, enoxaparin, or fondaparinux. Bright 4 study that came out of China, which is a very well-controlled, large randomized controlled trial, showed that prolonged infusion of bivalirudin provided significant mortality benefit, reduction in stent thrombosis in patients who have had bivalirudin as against heparin. And that is a move that we are seeing in a lot of institutions in Australia, including in our center. What about cardiac arrest? If the patient has been resuscitated and spontaneous circulation restored, there's no recommendation for routine invasive therapy or angiography unless the patient has persistent ST elevation. So that's very important when you're communicating with your ICU colleagues who would always like to push for an angiogram for patients who have had a cardiac arrest. What about cardiogenic shock? In the setting of cardiogenic shock, when the patient is intervened upon, the recommendation is only to intervene on the infarct-related artery. There was a study called culprit shock study that showed those who had intervention of the index artery did far better than those who have had multivessel intervention in that setting. There's no recommendation for the use of balloon pump in this patient population anymore, and same goes to veno-arterial extracorporeal membrane oxygenation, ECMO. However, there is recommendation for the utilization of microaxial flow pump, such as Impella or ventricular assist device in this setting, based on this study called Danger Shock trial that showed those who were treated with Impella did far better than those who were treated with conventional therapy, including ECMO. Those who have presented with acute coronary syndrome due to spontaneous coronary artery dissection, routine invasive therapy is not recommended unless the patient is unstable. In that setting, you can try putting a stent in, but it's not an easy task because it can cause a prolongation of or propagation of the dissection further. So that is for the acute management of patient. Once the patient is stabilized and recovered, all patients should be referred to a multidisciplinary exercise-based cardiac rehabilitation program. The patient should be given education on good lifestyle choices, and also smoking cessation is significantly emphasized. If cannot be instituted without medical therapy, intervention by way of nicotine replacement, varenicline or bupropion is recommended. What about lipid modifying therapy? All patients are recommended highest tolerated doses of HMG-CoA reductase inhibitors, statins, unless contraindicated. And those who cannot tolerate statins due to mild intolerance, dose reduction or frequency change is what is recommended. The target LDL level is considered less than 1.4 millimoles per liter, or more than 50% reduction compared to the presenting values. But further benefit is obtained from obtainable lowest levels. That is to be emphasized. Those who cannot attain targets just with statins, addition of acetamide is recommended. And those who do not achieve target with both of these should be treated with PCSK9 inhibitors or small interfering mRNA inhibitors such as inclisiran, the injectable lipid-lowering agents. What about beta blocker therapy? Beta blockers are recommended by the guidelines only if the patient has LV dysfunction. So those who have preserved LV function, upon intervention, an active effort should be put in place to wean the patient off the beta blocker. ACE inhibitors and ARBs are indicated in the setting of low ejection fraction, diabetes, hypertension, or chronic kidney disease. Those who have a low ejection fraction can be also beneficially treated with mineralocorticoid receptor antagonists, such as spironolactone. Once again, I want to emphasize the guidelines recommend not using angiotensin receptor antagonist neprilysin inhibitor Entresto in the setting of LV dysfunction and acute coronary syndrome. Lo and behold, colchicine has come back to the fray. This drug was first used 3,000 years ago during the time of early Egyptian civilization, but now it has found its way to guideline recommended therapy for acute coronary syndrome, 0.5 milligrams daily, based on a large cohort of studies, including LODOCO-2 study and COLCOT study that were published not too long ago. How do we practically apply these guidelines in the clinical setting? It's very important to maintain open and clear communications between emergency department, cardiologists, general practitioners subsequent to the discharge, and also nursing and allied health staff. Based on guidelines, coordinated efforts should ensure seamless care transition to address all aspects of acute coronary syndrome treatment with the help of guidelines. And secondary prevention should be a significant focus subsequent to acute treatment. Challenges and solutions in guideline integration. As with anything, we have challenges in implementing guidelines. One big hurdle is clinical awareness variability between clinicians. Resource limitations is another significant hurdle, particularly in this part of the world, and resistance to change, because if there's a significant change from current practice, there may be pushback from clinicians to adopt those changes. Therefore, it is very important to provide ongoing training in regards to adopting guidelines. Workshops for skills development is a very useful way of facilitating this, and also development and utilization of decision support tools, particularly digital tools, will be useful in this setting. Once implemented, it's very important to perform regular audits, integrate the feedback received from such audits and studies, and also put in place performance metrics to make sure that the guidelines are adhered to and expected results are obtained from guideline implementation. What do we look at into the future, and what ongoing research is happening in this field? So the guidelines indicate that there may be genetic profiling in the horizon to help customize treatment by identifying patient-specific gene variations so that the patient is given tailored therapy. And also biomarker-driven strategies will be integrated into guidelines to provide precise treatment decisions and enhance drug efficacy and reduce adverse effects. We are about to launch a randomized control trial to look into the utility of an agent delivered by an adenovirus vector in the setting of acute coronary syndrome and reduction in major adverse cardiovascular events in the very near future. Is still with the ethics committee scrutiny, but that is where our clinical medicine is heading right now. So in conclusion, integrating updated acute coronary syndrome guidelines is essential to enhance patient outcomes and clinical effectiveness. Education and teamwork among healthcare providers to overcome challenges in implementing new guidelines should be an emphasis. And effective care delivery now and in the future depends on continuous guideline adoption and cooperation. And as we know, guidelines get renewed every 5 to 10 years, and during that period, a lot of evidence in regards to medical innovation comes to light. And so therefore, a system of integrating live updates into the guideline development systems would be another future direction that we all should be looking into. Thank you very much.
Thank you, Professor Jayasinghe. We will now proceed to the next speaker, and then afterwards we will have our panel discussion.
Yeah, so let me introduce the next speaker, Dr. Paul Chiam. I hope I got your name correct. He is an interventional cardiologist, graduated from Dean's List of National University of Singapore, and awarded the Gordon Ransom Gold Medal for being the top candidate at the National University of Singapore, the Master of Medicine exam. He trained in general and interventional cardiology at National Center for Singapore, and subsequently he did his advanced fellowship in interventional cardiology at the Lenox Hill Heart and Vascular Institute of New York. He performed the first ever TAVI procedure in Asia, and now he serves as a proctor across the region. He performs all the complex coronary angioplasties, carotid and peripheral and structural interventions. He is currently working as an adjunct associate professor at National University of Singapore. And he is going to talk to us today, heart failure management, embracing guideline direct medical therapy. It's over to you, Paul.
Thank you, and good afternoon to everyone, and thank you to the organizers for inviting me. So as you can see, I'm an interventional cardiologist, so this is something that we all look after patients, but it is not my primary specialty, although I've been privileged to manage some very sick heart failure patients in the course of doing mitral edge-to-edge repair. So recently I had one refractory patient, class 4 NYHA, and I think I learned a lot a lot from that patient in particular, and this is, maybe I can share some of the insights with all of you. So you can see that heart failure now encompasses a whole spectrum. I think the mainstay is drugs, which we have a lot now, and some of them are very, very good. But you can see the devices, CRTDs, the cardiac resynchronization therapies. This has been around a long time. And more recently, in the past 10, 15 years, we are increasingly doing this mitral edge-to-edge repair for very severe functional mitral regurg patients with very bad heart failures. And of course, my partner is a heart failure specialist, and he manages all our patients with this left ventricular assist device that you see in the diagram on the right side. So some of these patients are really sick, and they've done very well over the last decade or so. So I think in medical school, we just taught about heart failure, and that's all we knew. And then suddenly, when we become a cardiologist, in the last recent years, you see that now we've divided patients into heart failure with reduced ejection fraction, and simply the other group would be heart failure with preserved ejection fraction of half REF and a half PEF. So it's really a mouthful, but I think you just split them up into these two would be probably the easiest way to look at these patients. So I think this is the commonest group, the patients with reduced ejection fraction, and I think spend most of my time here. And this, starting with the case, you can see one of our patients that we managed together with my colleague. This man coming to us with severe heart failure. The NT-proBNP is 25,000, so that really is a very severe patient, and the EF was only 25%. So your classic low ejection fraction patient, and you can see that his medications were already quite a lot. Entresto, 50 milligrams twice a day, dapagliflozin, the SGLT2 inhibitor, of course, the diuretics that we normally use, and a whole lot of drugs for other conditions. So we knew from years ago that the pillars of heart failure treatment included ACE or ARB, beta blockers when they are clinically dry, and the MRA is the mineralocorticoid receptor antagonist. So these were the three pillars that we've all been using for many, many years. But we also know in recent years that heart failure is not just the heart, but the whole system goes haywire. There's a lot of neurohormonal modulation, and everything comes some too much and some too little. So you can see there's activation of the sympathetic pathway, so a lot of deleterious effects from there, activation of the RAAS system, the renin-angiotensin-aldosterone system, and also then the counterbalancing side, there's increasing production of natriuretic peptides trying to do the opposite, trying to dilate the blood vessels. But these drugs, these peptides get inactivated by an enzyme called neprilysin. So this is what we understand, and we then come to have this new drug on board, which was released several years ago, but really a very good drug for all our patients now. A combination of angiotensin 2 receptor blocker plus a neprilysin inhibitor, so what we call ARNI. Okay, and I think this is a blockbuster drug that's changed a lot of management for our patients. Main problem with this drug is that the blood pressure tends to drop a lot. So you can see the valsartan or the ARB component blocks the renin-angiotensin-aldosterone pathway, which is good. We don't want too much vasoconstriction. We reduce the sympathetic tone. We reduce aldosterone, decrease myocardial fibrosis. And the sacubitril component in this drug then inactivates the neprilysin enzyme. And then that prolongs or lets the good natriuretic peptides accumulate. And again, that has good effects by reducing blood pressure, vasodilatation, etc., etc. So this is a drug that was designed to hit both pathways at the same time. And this was a trial that showed that this drug was really, really useful, the Paradigm HF trial, where it was randomized against the gold standard, which is an ACE inhibitor, enalapril. So this trial enrolled patients with reduced ejection fraction and elevated proBNP. You can see, I don't want to go into that, but they were all maximally treated with the best medical therapy at that time. So 8,000 over patients randomized to this class of drug against enalapril. And you can see that when you follow these patients, the primary endpoint of reduced death from CV causes of first hospitalization for heart failure was significantly reduced with this new drug as compared to someone on enalapril. And not only a combined endpoint, but the individual endpoint of reduction in cardiovascular mortality, which is probably important, more important than the combined endpoint, was also in favor of this new medication. And again, a separate endpoint of just hospitalization for heart failure was reduced with this new drug. And more importantly, the patients experience a better quality of life, which is, I think, to them maybe more important than what we think of mortality, is that they live better whatever time they have. And I think for the 3 years out to this trial, you can see that the quality of life for these patients are much better than those on ACE inhibitor alone. And I think the more reassuring thing is that there is no additional, not much more side effects of this drug as compared to the ACE inhibitor. In fact, there's less incidence of cough. I think the only thing that you will experience more using this drug on patients is that there's more symptomatic hypotension, and as you can see from the way this drug acts. So I think nowadays, if we can use this ARNI, it's probably recommended that we substitute this class of drugs over ACE or ARB for our patients with heart failure who remain symptomatic. And or we can also nowadays use this drug as a first line for patients coming in with the first episode of heart failure over ACE or ARB if they can tolerate it. And just bear in mind that they should have a blood pressure that should be, be able to tolerate. Normally we take about 100 at least, because they will drop the pressures. And you have to have a patient with a minimum renal function of at least 30 mils per minute. And if they're already on the ACE inhibitor, don't forget to stop the drug for at least 24 to 48 hours, because there is a high risk of angioedema if you start this ARNI drug when they are still on the ACE inhibitor. So next group of drugs that we use, this SGLT2 inhibitor. So many times I start, some patients will ask, why am I on this drug for diabetes when I don't have diabetes? And I think this is where the evidence comes in for patients with heart failure. So we know where this SGLT2 acts on the proximal tubule to reabsorb sugar or glucose. And these inhibitors block this pathway and therefore lets the patient pass on more sugar. There is a diuretic effect by osmotic diuresis. But I think you see that not only does it reduce this sugar, but it also has cardio and renal benefits. And now our renal colleagues also use this drug to try to preserve the renal function, reduce proteinuria in patients with or without diabetes. Again, it's a very strange thing to some doctors who are not familiar. They say, why are you on this drug? And they stop it, but actually we're using for something else. So these are some of the effects that's postulated for how this drug works. There's a vascular and hemodynamic component to it, decreasing blood pressure, decreased arterial stiffness, improving endothelial function, which is important. And all these may be the reason why there's less cardiovascular events with this group of drugs. There's the renal effects that you see, and of course the metabolic effects in weight loss, improving the insulin sensitivity, etc., etc. So the trial that looked at this in patients with reduced EF against this HFrEF, assessing dapagliflozin against placebo, and in patients with reduced EF, and you can see that whether we had diabetes or not, it was split half and half in this trial. And we see that this SGLT2 inhibitor actually reduced the combined endpoint of CV death or worsening of heart failure on top of standard therapy. So on best medical therapy, this new group of drug, this new class of drugs actually improved the outcome for our patients with heart failure. And the endpoint separated early on as early as at 1 month. Okay? By day 28, the curves start to diverge. And again, not only that, it continued to diverge as the trial went on. So you can see again, whether you had diabetes or not, this group of drugs seem to work very well for patients with heart failure. And also whether again, this is just to show you that whether you had diabetes or not, the incidence of worsening heart failure was better with dapagliflozin. And again, reassuring to see that there was no difference in patients who were put on this drug versus those on placebo. There's no increased incidence of any of the side effects that were tracked during the study. So similarly, for the other drug that's around that we're quite familiar with, empagliflozin, this Emperor reduced study, randomizing about 3,700 patients. And you can see again the same direction. So it's quite consistent by class, at least for these two drugs. There's a reduction in cardiovascular death or heart failure. And again, if you just look at the primary one endpoint of heart failure, reduction is better with this drug. And this trial also showed that the renal outcomes were better in patients given empagliflozin. So again, safety-wise, no difference with if you're given placebo or this drug. So reassuring to see there's no increase in hypotension. More importantly, no increase in hypoglycemia and no cases of the ketoacidosis. So now with the guidelines, we can see that this SGLT2 group of drugs are recommended for all patients with HFrEF to reduce the risk of heart failure, hospitalization, and cardiovascular death. So now the guidelines incorporate all four classes of these drugs, the ACE, ARB, or ARNI. Actually, probably ARNI would be the first choice if you could, if the patient can tolerate it. Beta blockers has been there, MRAs, the antagonists, and of course now the SGLT2 inhibitors. And you can imagine that if you combine all four classes, you can theoretically achieve a relative risk reduction of nearly 60% for our patients. So this is a remarkable improvement of how heart failure has been treated over the last maybe 5-10 years. So just to focus a short few slides on heart rate in heart failure. We tend to forget this drug, including myself. I don't use it all that much. In the course of preparing for this talk, I noticed some of my patients are still on this drug. And the drug is called ibabradine. And this is a trial that examined the use of this drug in patients with heart failure. They enrolled patients with heart functions less than 35% and with a heart rate of more than 70% on best medical therapy. And you can see that the primary composite endpoint of cardiovascular death and hospitalizations for heart failure was reduced with this drug compared to placebo, but I think was all driven mainly by a reduction in hospitalization for heart failure. So there's probably no mortality benefit with this drug, something that we can think about using if the heart rate remains high. And this is what the guidelines say. So after the best medical therapy, all classes on board, and the heart rate is still high, maybe we can consider this drug to help improve the softer outcomes. At least they don't come into hospital that often. So just to touch a bit on this class of drug, which I used recently for one of my patients in preparation for the Pascal edge-to-edge procedure. There's a patient I mentioned in class 4, he was almost in cardiogenic shock, and I really had trouble on high-dose diuretics, beta blockers, small doses of Entresto, and I was just asking myself, what else can I do to help him? So this is a soluble guanylate cyclase stimulator. We know that in heart failure, again, all the counter-regulatory hormones, what it does is that it reduces the production of nitric oxide and makes some of these pathways less sensitive. And these are things that are bad because there's worsening endothelial function, etc., etc. So this new class of drugs we call vericiguat, what it does is it increases the production of nitric oxide, sensitizes the body to this pathway, activates the soluble guanylate cyclase so that we have more nitric oxide, which obviously is vasodilatory and good for the endothelial function. So in this Victoria study, patients who had reduced ejection fraction heart failure, they were on best medical therapy, they were randomized to this drug versus placebo. And this was about a 5,000 patient trial, and can see that the maximum dose that they used was about 10 milligrams. In my patient, I was only able to use 5 because of the pressure dropped further. So that's also the same issue that we face with Entresto. So you can see that in this trial, there was a reduction in all-cause in cardiovascular death and heart failure hospitalization if we used vericiguat on top of best medical therapy versus placebo. So that means patients on Entresto, they are on beta blocker, they are on spironolactone, they are on SGLT2, and now a fifth one. So it's a lot of medicines. And the pressures are all, I think that's the main problem, the pressure is already very, very borderline. And again, it's driven mainly by reduction in heart failure hospitalization. So my patient, fortunately, he's been out of hospital for the most part, and is now, after we actually managed to perform the Pascal edge-to-edge repair. He's now back to near class 1, able to walk kilometers from a guy who was bedbound, who was basically in cardiogenic shock. So this is what we have, and we have this drug on board with him too. So the guidelines suggest that you can use this as a class 2 drug, after you exhausted all other options, and maybe this will help them improve their symptoms. So this is a patient that I showed you at the beginning with the pro-BNP of 25,000. You can see now he's on one ARNI, he's on beta blocker, nebivolol, he's on spironolactone, the MRAs, he's on dapagliflozin, and he's on baricitinib and on furosemide. But the furosemide dose is actually very small now. And he was wheelchair bound, if you remember on the first slide. And now he's able to just, this is our clinic, and he's walking around the hallway. All right. So that's for heart failure with reduced ejection fraction. Now we go to the more counterintuitive subject, which is heart failure with preserved ejection fraction. So a lot of people are asking, how does this happen anyway? How do you get HFpEF? So again, one case to show you, 87-year-old male that we treated, hypertension, atrial fibrillation, and wheelchair bound for the last 9 months, breathless, some leg swelling. And you can see his medications, the Xarelto for the AF, he's on Micardis ARB, he's on a beta blocker, and a bit of a diuretic. So the investigations-wise, you can see that he's really overweight, 105 kilograms for Asian men is really big, and in atrial fibrillation, lower limb pitting edema up to the thigh, also clear-cut heart failure. And investigations-wise, not too much to say there, normal kidney function. And the ECG showed AF, there was left axis deviation and probably a progression. So this is what we see in some of these patients with heart failure. So his echo showed the EF of 62%. So that's a normal ejection fraction. He had moderate AS. Don't think the moderate AS was the cause of his heart failure. Normally, we don't see patients with moderate AS coming in like that. You can see that there was severe tricuspid regurg, which we see in some patients, and dilated IVC, which indicates that there's a kind of overload in the system. So in summary, it's octogenarian, hypertension, atrial fibrillation. So we classify him as a heart failure with preserved EF, HFpEF, right? And wheelchair bound because of the extreme breathlessness. So what do the guidelines tell us? I think previously there was really no good treatment. It's treating the risk factor, the other comorbidities, and just using diuretics. Nothing else has been proven for HFpEF. So this is the first, I think, class of drugs that's been shown to help. Again, the SGLT2 inhibitors, Emperor Preserve. We saw the Emperor Reduce study, and now they tried this in patients with preserved EF, nearly 6,000 patients. And here, all the trials define preserved EFs as more than 40. So anything, because we know that usually if you are more than 40%, your lifestyle and your lifestyle or your prognosis is pretty much almost like a normal person. And you can see in this study, the curves diverge early on. If you use empagliflozin, the patients did better, reduction at primary endpoint of cardiovascular death and heart failure hospitalization. Okay, and again, it diverged very early on from day 18 of the trial. So, sorry, I think I went away. So again, we see the reduction in primary endpoint of CV death and heart failure hospitalization, probably driven mostly by reduction in heart failure hospitalization. And again, the benefit in terms of the renal protection was seen. But for many of these patients, I think they're not asking to live longer. They're probably asking us to treat them to live better. So we can see that when this trial was published, it was really the first drug that showed any benefit in patients with HFpEF. Because when you look at candesartan, which is ARB, there was no benefit. Irbesartan, similarly, perindopril, ACE inhibitor, no use. Spironolactone, just missing out. Entresto, also no use, surprisingly. So that was the big disappointment in the last few years, that Entresto didn't make a difference to this group of patients. Same thing, and then dapagliflozin came about. They did this DELIVER trial, similarly with about 6,000 patients testing to placebo. Again, very robust class effect, reduction in CV death and heart failure hospitalization. And again, the benefit was seen very early. Within 2 weeks of starting the medications, the patients already started deriving benefit. So now the guidelines state that if you have a patient with HFpEF or preserved EF, SGLT2 should be used for their treatment. And just more recently, I think about less than a year ago, this was published in the New England Journal of Medicine, the Fine Arts trial using finerenone, so another MRA, but a non-steroidal one. And this trial showed that there was a 16% risk reduction in CV death and heart failure hospitalization for these patients. So probably this will hopefully be another drug that we can use. We have to kind of wait for it to become part of the guidelines. But I think with this, maybe it's a good reason for us to start using it on some of our patients before the guidelines come about. So the state of HFpEF treatment, I think diuretics and SGLT2 are the mainstay. And of the SGLT2 inhibitors, I think only dapagliflozin and empagliflozin have evidence. And I think we should be aggressive with treating their comorbidities. And I think the mineralocorticoid receptor antagonists, in particular finerenone, which has been shown in that Fine Arts trial, probably will be included in the guidelines in the near future. And perhaps some of these GLP-1 antagonists that we know that's now in the news, maybe will be useful for patients with HFpEF. So coming back to our patient, you can see that we managed to reduce his weight from 105 kilograms to 83 to 76, and then now 74 kilograms. And basically, on top of the initial drugs, we've added empagliflozin, which is guideline directed. And you can see that we still use spironolactone. Maybe we're hoping that the finerenone will be a class effect. It's a very expensive drug. I don't think our patients can afford this drug at this time. So spironolactone is good and cheap, so we use that. And again, you can see that it's a different patient, by the way, not the same guy that you saw. Now that he was wheelchair bound, and now he can do that walk along our hallway again. So a really better quality of life for a very elderly patient. So finally, just a few words. My partner does this. I don't do it, but I think it's something that I've seen benefit a lot of patients. And this percutaneous, not percutaneous, left ventricular assist devices that they put in. Initially, when we first started this, it was a bridge to transplant. But nowadays, because the availability of hearts are so few, it is now a bridge to recovery. And for some patients, it's a destination therapy because there simply is no hearts available for most patients. So this is how it looks. The pump is implanted by the surgeon. It takes blood from the left ventricular apex, pumps it back to the aorta, that connects to a drive line coming out of the body. Very small pump. If they wear clothes, you probably can't see them. And they actually are probably in the community. And you can see the survival is much better now as the devices improve. The 2-year survival for a patient on HeartMate 3 LVAD is about 83%. So compared to when we first started, where there was 2-year survival of only 50%, it's now really much, much better. And this is how it looks. You can see some of these patients, maybe some of you recognize Dick Cheney, the guy on the top left, and many patients who actually go back to their lifestyle, right? Go back to the gym. You see that that's the guy on the right lower corner is wearing the carrier bag for the externally powered battery. And they can lead as normal life as possible. So I think to end off the key advances, heart failure therapy, I think you saw for the patients with reduced ejection fraction or HFrEF. ARNI is probably a big group now. SGLT2 inhibitors, dapagliflozin and empagliflozin, on top of the usual beta blockers and the mineralocorticoid receptor antagonists. The soluble guanylate cyclase inhibitor, vericiguat, will be useful. Ibrabadine for patients whose heart rate are still high after the optimization of medical therapy. And for HFpEF, we now have a class that's proven, the SGLT2 inhibitors, and probably to come finerenone, which is MRA. And I think lastly, for the very, very advanced heart failure patients, we have ventricular assist devices. And of course, the CRTDs, cardiovascular resynchronization therapies are there. And of course, for some of us who perform this procedure, the mitral edge-to-edge repair for severe functional MR. So in conclusion, I can see that the rapid advances in heart failure therapy for both drugs and devices have resulted in improved survival and quality of life. And I think we should be more proactive in treatment rather than wait for patients to deteriorate. And treatment devices like VADs are now the standard of care for very, very severe heart failure patients. So thank you very much.
Thank you very much, Dr. Paul Chiam, for that insightful lecture on heart failure. I think you gave us basic insights as well as deepening of our understanding on latest management of heart failure as well. Thank you very much. I think it's time to move on to the next lecture.
So the next speaker will be Professor Derek Connolly. Professor Connolly is a consultant cardiologist at the Midland Metropolitan University Hospital, the Priory Hospital, and the Birmingham City and Sandwell Health campuses. He holds honorary academic appointments at Ashton University and Institute of Cardiovascular Sciences, University of Birmingham. Professor Connolly trained in Edinburgh, Cambridge, London, and San Diego as a Carnegie Scholar, earning a first-class pharmacology degree from Edinburgh, where he was the Brunton medalist and the Caseby bursary holder. His BHF-funded PhD in molecular cardiology was completed at Cambridge. With a large clinical practice and over 100 invited lectures annually, he is particularly recognized in preventive cardiology. He serves on the Council of the UK Primary Care Cardiovascular Society and is chief or principal investigator in multiple major cardiovascular trials. In 2024, he was awarded an honorary DSc by Aston University and appointed Vice Chancellor's Professorial Fellow in Health Research. And he will speak to us on chronic coronary syndrome, navigating long-term management strategies.
Thank you very much indeed. Hopefully we'll build on the previous two speakers. In 2024, we got an update of the European Society of Cardiology guidance on chronic coronary syndromes. And I'm going to tell you where we are in Europe regarding that. But let's go back. Only in 2019 was the term chronic coronary syndromes invented or adopted. And the question is, what is that? Well, the answer to that is it's everything that Rohan didn't speak about in acute coronary syndromes. So it's classic patients with chest pain presenting with angina, but it's also patients who are known to have coronary disease and are stable, or those that you find have coronary disease on scans, on ECGs, on echoes. And it's also those patients with ischemia with non-obstructed coronary disease that we know is due to microvascular spasm. So it can have fixed obstructions or it can have variable obstructions largely due to coronary spasm. And you all know what the main symptoms are. And you also know that the more of these standard symptoms, the more likely someone is going to have classic coronary artery disease. However, we all know the diabetics who have terrible disease and have never had symptoms. So we need to bear that in mind. And I think when we evaluate a patient, we can start thinking, what is their family history? What risk factors do they have? And then we can start doing some simple tests like an ECG. These days, you can do bedside echo in many places and work out whether someone is likely to have heart disease. But at the end of the day, the way you find out whether someone's got heart disease is to do investigations. So the first investigations you might do to work out risk would include these. These are the current ones recommended by the European Society. And they're all the ones you would predict, but they're not everything. This is what I do. And I would suggest to you strongly that you should do more ACRs, albumin-creatinine ratios of the urine. I see that raised a lot, and it's a major risk factor. And lipoprotein A, 1 in 5 of us in this room will have a raised lipoprotein A, and that significantly increases your risk of cardiovascular disease. But at the end of the day, we do testing. And historically, we did lots of invasive angiograms, and then we moved to functional tests, MPIs, PET scans. But then over the last 20 years, we've seen a rise in CT coronary angiography. And it's important to realize that in the UK, that is our #1 test. I'll show you why in a second. But I was talking to many of my previous fellows from Sri Lanka. I've come back, and I know Naushad Ali is doing CT scans in Kandy and in Colombo. So this is where it's going here as well. And the bottom line is it's all about prediction. You can predict things using scores. You can predict based on the number of risk factors. You can predict the older you are, and if you're male, you're more likely to have cardiovascular disease. But then you can look at other tests that tell you whether someone has heart disease. And calcium scoring is very much there. If you have coronary calcium in your coronary arteries, that's easily seen on a CT scan. You can quantify it, and that gives you an additional risk factor. So let's have a look at the role of imaging in cardiovascular stratification. That's the Midland Metropolitan University Hospital in Birmingham, by the way. Now, can anybody tell me what that is? It's a duck, okay? You know it's a duck, I know it's a duck. It's very simple. So the hardest test, the test that definitively tells you whether someone has cardiovascular disease, is imaging, looking at the coronaries either on CT or an invasive angiography. The other tests, probably you've got coronary disease, but you don't know. So the vast bulk of patients, we're going to be using imaging to look at coronary arteries. So the European guidance is that the appropriate test for that massive bit of the pyramid that's at the base is going to be cardiac CT. At the top 15%, you'll go straight to invasive angiography. And there is a role for functional testing in the middle. Having said that, cardiac CT, and I'm going to show you data in a second, now in our hands also has functional data. So how do you manage someone who's come to your rapid access chest pain clinic? It sounds like they have angina. You've done the ECG, it might be normal. What test would you do? Well, you can see here in the European guidance, you've got the option of doing an imaging test, CT, or a functional test, such as MPI, or you can do both. And we often end up in this situation doing both if we're uncertain. So let's give an example. This is a real patient. It's a 40-year-old general surgeon who phoned me up and said, I've got chest pain. And we did some blood tests. He's got a high total cholesterol, a high LDL cholesterol, a high lipoprotein A. And as with many patients, he's got a low HDL cholesterol. Watch out, total cholesterol doesn't tell you everything. For those that were at the breakfast meeting this morning, remember a total lipid profile should also include a lipoprotein A. But you can also see, and I was the first person to diagnose it, he's got a raised HbA1c. He is diabetic, and his BMI is 32. He told me he'd put on about 2 stone in the last couple of years during the pandemic. But all of his other tests, including his ECG and his echo, were normal. He had normal left ventricular function. Now, he's 40. I could do a calcium score, but as I'll show you in a second, it's not so good in younger patients, but in older patients, it's very good. And once you've got calcium, and more importantly, the more calcium you have, we measure that in Hounsfield units. We have a score called the Agassiz score. It gives you risk. And we know that if you're older, and we'll talk about what older is in a second, and you have no coronary calcium, your risk of having a cardiovascular event is substantially reduced against the general population, whereas the opposite is also true. The higher your calcium level, the more likely you are to have a heart attack or a stroke. And in fact, we can now look that if you have an Agassiz score of 300 and you've not had a heart attack and you've not had a stroke, your chance of having an acute event, your chance of dying is the same as someone who's had a heart attack. So having a loss of calcium there, and I see 300 every day, means that your risk is equivalent to someone who's already had a cardiovascular event. And we've shown this, that you can use it with MPI scanning. We showed this a few years ago, where it adds to it. The functional test and the calcium score together, both non-invasive, are very predictive of future events. So on the other side of the fence, if you are older, and in this study, older was 69, if you're certainly over 50, but over 60 for definite, having zero calcium on a CT scan means that your risk of having significant cardiovascular disease isn't zero, but is substantially better. In fact, it's the best test to effectively, in older patients, exclude future events. So that's led to this. This is from my friend Matthew Rudolph, and Matt and David Marin have written this paper that says that if you have zero calcium, we can probably ease off. Now, I'm going to argue that that's not true for younger patients, and I'll show you the data in a second. But as soon as you've got any coronary calcium, you should be on lipid-lowering therapy. And in the European Society, as of last week, we now recommend combination therapies up front, statins and ezetimibe. If you get to 100 to 300 Agatston score, and this is eminence rather than evidence, we're suggesting antiplatelet therapy, and over 300, we're really treating patients as though they'd had a previous heart attack. Now, why have I got a caveat about younger patients? Well, we showed, and in this paper last week by my friend Jonathan Leipzig, this showed that you can be 40 and only half of the patients who've got significant coronary disease on CT have any coronary calcium. Coronary calcium is the equivalent of the GON complex, GHON. So, or tuberculosis you see on a chest x-ray. It takes time for it to form, and younger patients may have significant disease and not have any coronary calcium at all. So beware coronary calcium scores in younger patients, but if it is there, it's incredibly important. And one of the first things I teach all my new residents, all my new fellows, is have a look on the system. In the UK, we have 25 years of CT scans on the PAC system. And historically, it wasn't reported by the radiologist if there was coronary calcium or vascular calcification. It's very easy to see. You can look it up, and instantaneously, you know that patient with chest pain has coronary disease. Now, people say, well, it's not the same as doing a formal calcium score, and it's not, but all of the studies suggest the more coronary calcium you have, the more equivalent it is. So it's a very easy way, retrospectively, of seeing whether someone has coronary disease. So we've been using, since we set up the CT program nearly 20 years ago, we've been using it as our diagnostic test. The CTs on one side, the invasive angiograms on the other side, and very much we see exactly what we see on CT in the cath lab. What's more, we've got data now from Scotland, the Scott Heart study, done by my friends there, showing that early CT as part of the rapid access chest pain system is very beneficial. That's the 5-year data. We've got 8-year data. It's cost effective, and it largely reduces future MIs by the addition, we think, of medications such as lipid lowering. So in 2016, NICE in the UK put CT scanning as our diagnostic test of choice over other testing, which was important. And we tested this in a big study, international study called PRECISE. With PRECISE, we added in something called heart flow. I'll show you that in a second, which was a functional test. And the initial study was very positive. We've recently had the long-term mortality data, and it's very positive. So this is a non-invasive way of reducing the number of invasive angiograms. And we do it very simply. It's a one-stop test. The patient comes in, we put them in the scanner, we report it immediately, we tell them the results, we make a plan. Yes, some patients get admitted to the cath lab. Most patients are told it's medications long-term, 4 out of 5, and that's it, sorted. So it's a one-stop clinic. The patients like it. What's more, we've enhanced it. CT scan keeps getting better, and about 5 years ago, I introduced a technique called heart flow to the UK, which allows us to look at the flow down the coronary arteries. It's equivalent to the pressure wire studies in the catheter laboratory. So here is our surgeon, our 40-year-old surgeon's CT. He had no coronary calcium, but you can see a tight lesion there in the left anterior descending coronary artery. So guess what? We took him to the lab. He's got the tight stenosis, and a few seconds later, we've put a stent in, and he's sorted. And we don't just use CT. If someone comes in with a heart attack, we might put them in the CT before bringing them back if they also need a chronic total obstruction open. We found that incredibly useful as well. And as you've heard from Rohan, we use lots and lots of imaging in the catheter laboratory, OCT, IVUS. But we also have increased imaging in the CT scanner. Now, that's really useful because in the old days when we wanted to do a clinical trial to see whether cholesterol reduction therapies improved plaques, reduce plaque vulnerability, we would have to bring them back and do intravascular ultrasound. We can now do it on CT scans, and in fact, it's been done. This is with a therapy called Vascepa, a very purified fish oil, and again, this is Matt Mudov's study, effectively showing at time 0 and at 1 year, you can see regression of disease. And as scanners get better, we're seeing more and more of this. So it's a great way of checking the patient to see that things have improved. And with AI, artificial intelligence, with computers getting better, with scanners getting better, that means that this is going to continue to improve. And we can now not only quantify one plaque, but the whole of your plaque burden in your coronaries. Which ones are vulnerable, which ones are not vulnerable, which ones have healed. Really important. So this is all getting better. So now, this is one of the company slides, this is HeartFlow. We can do the equivalent of pressure wire studies on the CT, FFR CT. We can actually plan where to put stents in, what size of stents, whether the patient would be better for bypass surgery. If someone needs a TAVI, I mean, we've heard about those, a percutaneous aortic valve. We don't do invasive angiography anymore. We do a CT TAVI to look at the coronary arteries, to look at the aortic route, to look at the route in, to make sure that it's the right thing to do. A lot of this doesn't need radiologists. It can be pre-read by the computer. Obviously, we get plaque analysis. We can work out the total plaque volume and how much vulnerable plaque we've got. But increasingly, using AI, we can work out how much blood is going down each artery and how much heart, how much muscle each artery is subtending. So we can get myocardial perfusion as well. However, I think one of the most exciting things I've seen is my friend Harris Antonides, who's professor in Oxford, and his team have developed this. We've helped them a little bit with it. We all know that inflammation is a risk factor for coronary disease. Paul Ridker's been telling us that for years. We've heard about colchicine from Rohan. But Harris can see it on the CT scan. He can look at something called the fat attenuation index, and you can see on the left there a nice quiescent artery. On the right is a hot artery, an inflamed artery. We saw a lot of this in COVID, which might have explained why we had the cardiovascular events in COVID. So we can work out how inflamed an artery is. So the guys in Oxford have taken this into large data sets. This is the Erlangen data set from Siemens, and you can see that it's highly predictive of cardiovascular events on top of everything else. So CT scanning continuing to get better, showing us something different again. And now they've got it, inevitably, the company coming out of this. This is the Carry Heart Score. So the Carry Heart Score works out how inflamed your arteries are. It works out what your total plaque volume is and whether that is vulnerable plaque. It puts in all of the other data. We put in things like Neuroscore and Q-Risk, and gives you a total and extremely predictive score of future events. Now, that's incredibly useful. When someone has a CT, by the way, all of my patients these days have a smartphone. I show them the images. If they've got coronary disease, I make them take a picture of the images. And I say to them, when you decide to smoke your next cigarette, when you decide not to take your lipid-lowering therapy, have a look at that photo and then make the decision again and make it better this time. So it is one way of, yes, excluding disease in some patients so they don't have to take as many tablets, but emphasizing to the patients that they are very high risk. So what is medical therapy? Well, medical therapy is drugs for symptoms, but it's drugs for prognosis. There are lots of anginal drugs, and they all, to some extent, work. We use these days lots of ranolazine, which is off patent in the UK, and is a superb drug. But none of these have major prognostic benefits out with things like heart failure with beta blockers and ivabradine, as you've heard. But some drugs do have a phenomenal survival benefit. You've already heard about SGLT2 inhibitors. The empagliflozin regulatory trial, if you have diabetes and you have coronary disease, it lowers your mortality by 32%. Total mortality, New England Journal, by 32%. That is phenomenal. That is bigger than the effect of streptokinase in ISIS-2. It is an enormous effect, and we're not using it. This is off patent. In the UK, the empagliflozin's lost its patent. It is £10 a year. So not cheap, but much, much cheaper than it used to be. On the other side of the fence, we all know about Ozempic and Wegovy and Mounjaro. Well, we've been using these for 20 years. These are iterations. Mounjaro is the iPhone 17, but we had the iPhone 1. And we've been doing trials. But if you look at semaglutide in patients without diabetes who have BMIs above 27, which is virtually every one of my patients in the prevention clinic, virtually every one of them has a BMI above 27. And if you've got coronary disease and a BMI of 27 or above, you get a 19% reduction in total mortality by the use of subcutaneous semaglutide. So these therapies are absolutely revolutionary. In the UK, our pandemic at the moment is obesity, driving coronary disease, driving diabetes, driving kidney disease. And so we have 2 million patients on this now. Most of them, by the way, self-funding, which is remarkable. This is a drug that does have side effects, but patients don't want to come off it. Quite the difference to lipid-lowering therapy. It is really quite remarkable. So we've put this in the European Society. If you're diabetic, we don't use the old therapies anymore. Class 1 in green, if you have atherosclerosis, we're using GLP-1s, we're using incretins, such as semaglutide and tirzepatide, but we're also using the SGLT2 inhibitors first line. Okay, is there any evidence that this works? Well, I looked at the UK population with diabetes and coronary disease, over 50,000 patients, and I looked at what happened if you added in insulin, or DPP-4s, gliptins, or if you added in an incretin, a GLP-1 agonist. And there was a 50% reduction in total mortality if you were using a GLP-1. Now, there are confounders with real-world data, but this is phenomenal. So it really is changing things. So this morning I talked about lipids. I won't cover lipids again, but I am going to talk about blood thinning agents. Again, highly neglected. So it's an extremely complicated pathway, but ostensibly you have antiplatelet drugs and you have anticoagulants, DOACs in particular. And you can use them in combinations, and there are lots of trials suggesting this and that regarding antiplatelet drugs, and we are using them. And the evidence is with modern stents for many patients out with acute coronary syndromes, you can shorten the period of dual antiplatelet therapy to certainly 6 months, maybe even a month in high risk for bleeding patients. In ACS, by the way, a study at the European Society meeting in Madrid a couple of weeks ago suggests we probably should go for a year with dual antiplatelet therapy post-ACS. But we did this study. This is called COMPASS PCI. And instead of, after a year, just going down to aspirin, we gave, in a randomized blind trial, aspirin and baby dose, low dose rivaroxaban, 2.5 milligrams BD. And as you can see from this trial, if you'd had previous PCI, there was a 27% reduction in total mortality. Now, worldwide, this is off patent, it's cheap, nobody's using it. So a bit like colchicine in Rohan's lecture, nobody's using it, but certainly beneficial. But of course, you're going to say to me quite rightly, by the time you've added in the blood pressure treatments, great lecture early on blood pressure, by the time you've added in all those lipid-lowering therapies, I have lots of patients on triple therapy for lipids, you're going to be, if you come and see me, on 15 medications, polypharmacy. So that is an issue, and it may be poly pills and poly injections are the future. So what did we do with our surgeon? Well, post-PCI, cardiac rehab, exercise lowers your mortality, Cochrane analysis by 10%. Initially he was on dual antiplatelets, he's now on dual pathway inhibition, aspirin and baby dose rivaroxaban, no bleeding. He's on triple therapy for his lipids with high potency statin, with ezetimibe, with the PCSK9 targeted therapy, inclisiran, 2 injections per year, lowers your cholesterol by 50%. He's on both SGLT2 inhibitors, and he's been on an increasing dose of semaglutide, such that he's lost 2 stone. He was 40, he used to look 50, he now looks 30. His wife gives me cuddles because she's got her husband back. It's really remarkable. He's also on an ARB, I tend to use them rather than ACE inhibitors. He's on bisoprolol, and he's got a personal trainer. I am responsible for the use of personal trainers, I think, increasing massively in the Birmingham area. But more importantly, his metabolism looks good. His BMI now is 24. Come right down. His LDL is now 0.8. His HbA1c has normalized. He no longer has diabetes. If you can get the weight off, it improves. And he's just run a 5K charity run. He did it for cancer, bowel cancer, rather than heart disease, but good on him. It shows where we've gone. Okay, so lots of therapies, but who should we revascularize? This is the current European guidance, and one of the things I chair our heart team meeting. So I have about 30 people online, surgeons, interventional cardiologists, non-interventional cardiologists, and we debate each patient, and everybody gets a say, and in general we come up, I think, with the right answers, and that we've got in. And certainly, when we looked at 2018, this we used to have on the wall, pretty much everybody, Class 1A, Rohan's talked about evidence, Class 1A evidence, everybody got revascularization. And I'm going to run through that because most of it's still the same, but not everything is the same. Certainly for left main disease, either with or without three-vessel disease, multi-vessel disease, we revascularize. If you can do it by PCI with equivalent results to bypass surgery, that's generally simple left main, we can do it by stenting, but still the guidance suggests in pretty much all other cases we do bypass surgery. What about multi-vessel disease? Well, the one big study we've had is the ischemia study. The ischemia study was done around the world, funded by the NIHA in America. You had a stress test or a functional test, which was strongly positive. You had a CT scan, which excluded coronary disease and normal coronary arteries. If you had multi-vessel disease, you were randomized to medications or an angiogram with a view to revascularization. And people criticize this study, but you can see over half the patients had severe ischemia and another third moderate ischemia. And if you look at the CT scan, most of the patients had 2 or 3 vessel disease. Nearly 90% involved the LAD and half of them the proximal LAD. This is real disease. And when we look at the study flow, virtually everybody randomized to cath lab got cath lab, and about 80% got revascularized. You can see that during the period, about 30% of patients in the conservative limb got an invasive angiogram and about 25% were revascularized. 3/4 of the revascularization was by PCI, 1/4 by bypass surgery, and this was in the world's top units using the latest techniques. And the theory was this was going to show us that revascularization in chronic coronary syndrome saved lives, but the study was negative. No major differences in the primary outcome, and importantly, absolutely no difference. This is to 5 years. We've got the data 8 years in total mortality. Now, you can look upon this as saying it doesn't reduce mortality, but on the other side of the fence, it doesn't increase mortality either. It does reduce spontaneous MI, it does reduce unstable angina, but it increases heart failure. So there is a balance to be had. So no major groups there with benefits, but it does reduce angina. So it is certainly something to do that we're using. So revascularization certainly is something we're using. In acute coronary syndromes, it saves lives. In chronic coronary syndromes, left main, it saves lives. But in other conditions, probably mostly doing it for symptoms. And at that point, I'll stop. Thank you very much indeed.
Thank you, Professor Connolly, for that fascinating lecture. Could all 3 speakers and the panelists join us on the podium, please? Okay, shall I just start the discussion? Professor Rohan, Jayasinghe, when you were doing this talk on the acute coronary syndromes, I noticed that you tended to spend more time on the GRACE score and not the others. Was there any particular reason for that? Was it because of its real time? Or what are the reasons?
Yeah, thank you for the question. The question is whether why I delved more on the GRACE score than the other 2 scores that I mentioned. The first reason is both the Australian updated guidelines as well as the updated American guidelines specifically mention the utility of GRACE score, and it gives a very accurate prediction of the risk the patient is at, particularly at 6 months, so immediate to medium term. And it's quite easy to use. Majority of the parameters are clinical parameters and biomarker as well as ECG. The heart risk score is utilized mostly by emergency physicians to decide on risk stratification. American guidelines mention TIMI risk score, but Australian guidelines do not. And also we need to understand that none of these risk scores were developed by studies that were specifically aimed at developing risk scores. They were offshoots of other studies that were done for other purposes. So therefore, there's no specifically designed risk score at hand anywhere at this moment in time, but the guidelines and the evidence support the utility of utilization of gray score in preference to the other scores.
Professor Rohan, thank you for that excellent lecture. I also like to ask you a question. What your experience is in using drug-coated balloons in acute coronary syndromes? I know it's out of the guidelines, and whether you have any opinion as to whether it should be incorporated in the guidelines in the future.
Thanks for the question. The question is what my experience is with the use of drug-coated balloons in preference to stents in the setting of acute coronary syndrome. Well, the evidence base is lacking in the utility of drug-coated balloons in that particular context, and also there's the risk of increased incidence of dissections with the utility or utilization of drug-coated balloons. So therefore, it's not a preferred therapeutic modality, but in situations where there's concerns about using potent dual anculated therapy because of bleeding risk, or if there's technical challenges with regards to delivering a stent, using a drug-coated balloon could be a suitable alternative.
Derek, can you ask a question? Now, if you have chronic coronary syndrome, if you detect it, and you said that you like to do even LPA level, right? So you already diagnosed plaques. So you have high LPA levels. So will it be different that you approach? Your target will be different? So
really good question. So lipoprotein A, we all have. And the levels stay the same from when you're 18 months old to when you're 80, largely. The Brussels Declaration in March of this year was that it's a human right to know your lipoprotein A level. It's inherited from your parents. It's on chromosome 6. You get one gene from mum and one gene from dad. So the likelihood is that if they've got a high lipoprotein A, you're going to have a lipoprotein A. And per molecule, it's somewhere between 6 and 8 times more atherogenic. So, and it varies 1,000-fold. So it is something that is often responsible for a family history of cardiovascular disease. Now, at the moment, we've shown that if you lower LDL more, then you reduce that deficit. But the great news is we have 5 specific inhibitors coming to market within the next 5 years.
Thank you. My question is to Professor Lim. Now, when it comes to these SGLT2 inhibitors, now we all know in all these embedded trials as well as the trials which is regard to that, they have used the patients who are having the eGFR more than 20. So in that case, most of the recommendations that it came as that we need to consider the eGFR when we are prescribing this drug. So my question is now, there are patients with chronic renal failure, end-stage renal failure, with severe heart failure. So would you recommend giving this drug beyond this 20 eGFR, because the action of this SGLT2 inhibitor is independent of eGFR?
So I think the dapagliflozin, you can use them down to 15, if I'm not wrong, although the trial was that. But I think lower than that, nobody knows. For my patients, if they are end stage and lower than 15, we'll still try. I mean, because we really don't know what the data will be at that stage. But I think that you follow strict by the trial criteria, then I think they're around 20, 25, but DAPA says it can go down to 15, and I think that's about it. So the rest is all just try and see.
Thank you.
Yeah, I think thank you very much. This time is up. I can give audience one question. One question. Make it very brief.
Regarding the type 2 MI, is there any consensus in the management of type 2 MI?
Yeah, thank you for the question. Type 2 myocardial infarctions, unless there is significant coronary disease identified, correlate with the clinical presentation, management should be a conservative one, essentially antiplatelet therapy. And if there is an identification of a possible trigger, such as rapid atrial fibrillation, obviously treating the root cause, and standard therapy for acute coronary syndrome for conservative management should be put in place in that situation. Thank you.
think we are at the moment running short of time. So are there any burning questions on the part of the audience? Panelists? Yes, so let me thank all three speakers for some very insightful and quite fascinating talks. And before we conclude, we will need to present our tokens of appreciation. First to the speakers and then to the panelists.
Then Professor Paul Chiam. Professor Derek Connolly. Yeah, we have a token of appreciation for our panelists as well. And yeah, Dr. Bhathiya Ranasinghe. Dr. Tanya Pereira. Dr. Disna Amaratunga. Yeah, with that, I think, sorry, Dr. Mubarak, sorry. Yeah, I think with that, we had an excellent symposium today. And so I think I must thank all the speakers and the panelists, my co-chair, and for their participation. So we had very thought-provoking, insightful presentations. I thank again for all three speakers. And not only that, I think I have to thank organizers as well. And with that remark, we have to make it to a close. Thank you very much.
Could I now please invite Dr. Ushani Varia Perwa to award the certificates and letters of appreciation to our chairpersons.